With that, I would like to invite Professor Fauzia Khan, who is professor in anesthesia at Aga Khan University Hospital. Professor Fauzia has been my teacher in Aga Khan when I obviously spent about 6 months there. And I learned a lot during that 6 months, and it's nice to see her back here. And this is from her. Thank you.
Okay, good afternoon and Assalamu alaikum. I would first like to thank the organizers, of course, for inviting me to this meeting. And the topic I'm going to speak about in the next few minutes is about anesthesia safety. So anesthesia safety in the SAARC region, problems and solutions. I have no relevant financial or non-financial relationship to disclose in relation to this presentation, except that I chaired the Safety and Quality Committee of the World Federation of the Societies of Anesthesiologists. Now, next few minutes, first I'll talk about the importance of anesthesia safety. What are the problems in South Asian countries, and then some solutions. Now remember that anesthesia is non-therapeutic, and it is a specialty with inherent risks. And what are these risks? These risks are human factors, they are patient factors, medication, equipment, and system failures. Now, anesthesia safety has improved over the last few decades due to improved technology, introduction of minimum standards, safety checklists, guidelines, and many other things. But conditions, they are still challenging in lower and middle income countries where there is shortage of anesthesia providers, shortage of drugs, equipment, and failure to adhere to international standards. In 2012, Wu et al., they surveyed a total of 590 facilities in lower and middle income countries, and 35% of the hospitals had no access to oxygen, and 40% had no anesthesia machines. Now, unfortunately, the world did not pay much attention to anesthesia and surgery, and global funding has focused more on infectious diseases. In 2004, it was reported that the global volume of major surgery was 234 million operations. And around 2009, it was the same group who reported that poor access to surgery and safe anesthesia results in a much higher mortality rate. So in other words, there was a correlation between increased surgical rates and increased life expectancy. So it was the report of Lancet Commission in 2015 which highlighted the need to tackle these issues, specifically in the lower and middle income countries for both anesthesia and surgery. It was pointed out that there were 5 billion of the world's 7 billion population does not have access to safe anesthesia and surgery. And the World Health Assembly in 2015 also passed a resolution on strengthening the emergency and essential surgical care and anesthesia as a component of it as part of universal health coverage. Now, the SAARC region comprises of nearly 20% of the world population. So 1/5 of the world lives in the South Asian region. And we usually have a regional meeting of anesthesiologists, which is a subsection of the World Federation of Societies of Anesthesiologists every 2 years. And this was a session which was held earlier this year in Colombo, Sri Lanka. And we had a session on safe anesthesia where some issues were highlighted, and I'm going to talk a little bit more about these issues. So firstly, the manpower issues. There's shortage of trained and qualified anesthetists. There is high workload with limited remuneration. There is brain drain, mostly to the Western countries and also to the Middle East. There are fewer entrants into the specialty. That's also worrying. And then anesthesia is provided in some areas by non-physicians who are poorly trained and unsupervised. Now, this is the Global Anesthesia Workforce Survey, which has recently, this was published this year in Anesthesia and Analgesia. And this shows the physician anesthesiologist density in the SAARC countries. And you can see in most of these, is this the pointer? Oops, sorry, what did I do? Yeah. In most of the SAARC countries, the physician anesthesiologist density is less than 3. In some parts, it is less than 1 per 100,000 population. In contrast to this, this is the world map. So you can see North America, Australia, most part of Europe. The density varies from 10 to 20 per 100,000 population. Then the same thing applies to the equipment and medication. There are problems with availability and the standards for both equipment and medication. There have been very little investment in low-cost, robust, and functional equipment, which is meant for the lower and middle-income countries. And for drugs, there are no national or local mechanisms for dealing with drug shortages. As an example of equipment, I can give you the example of pulse oximetry. This was endorsed as a standard by WHO. It is also endorsed as one of the minimum monitoring standards by the World Federation. In 2010, Funk et al. Demonstrated that there are 77,000 operating rooms in the world where anesthesia and surgery are done without the use of pulse oximeters, and majority are in lower and middle-income countries. If we want to make any change, one should remember that it should be a sustainable change, and it requires a system change and a functioning healthcare system, which is very important for universal coverage of health. Another big issue is the administrative and political issues. There is no proper understanding of anesthesia-related resources and their overall impact on healthcare systems. There is lack of understanding of anesthesia being an essential part of secondary healthcare services. And anesthesia is now not merely limited to the operating room, and the administrators forget that anesthesiologist services are also required in emergency rooms, intensive care units, cath labs, radiology, MRI suites, pain clinics, resuscitation, ECT, etc. Now, this is a recent example of the mindset of administrators. For those of you who can't read Urdu, this is a newspaper report of a recent high-level meeting, which was carried out under the Punjab Healthcare Reforms Roadmap, where shortage of anesthetists was discussed in detail. But unfortunately, there was not a single representative of anesthesia specialty present in that meeting. Then there are safety issues. There is absence of culture of safety because people are not taught about it, not trained during their training, and their lack of opportunity to improve practice. It's not in their control in majority of places. So what are the solutions? The solutions can be global, they can be regional, or they can be national. There's a whole list of global strategies that can be taken up. There's the role of global organizations, global funding, international standards, standardized research, development of low-cost, robust equipment, donations from high-income countries to lower and middle-income countries, improving global coordination, and planning of global health needs. Don't have the time to go into the details, but just to give you some example, WHO, with the surgical safety checklist introduction, many of the countries have taken this up, and now data is coming up. There is evidence base that it is making some difference. WFSA started in 1955, World Federation of Societies of Anesthesiologists. It is constituted of 135 national societies, and it has come up with international standards for safe anesthesia. Lifebox Pulse Oximetry Initiative, it's a multi-organizational initiative which is aiming to have a pulse oximeter in every operating room throughout the world. Donation of equipment. Effective form of health can be provided by donation from high-income to lower and middle-income countries. But international guidelines need to be followed, and equipment should be practical for the receiving countries. So there should be some input from there. I've put two references there which are very useful articles in that respect. Then there are regional strategies. At least in anesthesia, World Federation has regional pockets. Like, for example, I gave you the example of South Asian region. And these have unique distribution of high and lower middle income countries in these regions. And these can get together and help and make strategies at these regional meetings. Common guidelines can be developed. For example, Helsinki Declaration is a guideline, safety guideline, which came up from the European Union. And regional safety committees, some of these regions have regional safety committee, and we are trying to make one in the South Asian region at the moment. At the national level, many things can be done. Patient safety should be a priority in national health policies. It should be recognized in healthcare budgets. There should be implementation of these health policy changes. There is a place for a national safety and quality committee, especially in the lower and middle income countries. Role of professional colleges. Role is that the curriculum should include safety modules when you're training people. And role of professional anesthesia societies. Many societies in lower and middle income countries, they only function for one meeting a year. So I think that function should be extended towards patient safety and should do a little more than that. And then, of course, the role of teaching institutions. So individual institutions and practitioners, they should have safety and quality committees and safety plans. There should be nurturing of quality within institutions, training of members in quality, and appointment of quality officers. Individuals as well can make a difference. There are various practices at individual level which decrease patient harm. For example, initiatives to decrease patient infections, decreasing airway-related complications, and following certain guidelines. So in the end, I'll just finish with a quote. This quote is from the policy brief of Global Surgery 2030. It says, although the causes of inadequate and inequitable surgical and anesthesia care are a global concern and responsibility, improvements in surgical care will ultimately be realized at the national level through the programs, services, and policies implemented in lower and middle income countries by national governments and delivered by local providers. The Global Surgery 2030 outlines key recommendations for countries to follow, and they include a template for national surgical plan that can accelerate surgical scale-ups and facilities with substantial health, welfare, and economic gains. Thank you very much.
Fauzia. We have time for a couple of questions. Can we get the mic, please?
This is a question more for, I think, the deans who are here from Pakistan as well. So I'm, as you know, from US, and we have an increasing role of what's called physician extenders or allied health professionals. So in Pakistan, there's a lot of kids who want to get into medical schools, and a lot of them don't get into medical schools. I think there's a huge opportunity to guide some of these kids into APPs or associated providers. And to your comment about the lack of anesthesiologists, we have what's called CRNAs in the United States. Rural US is just like Pakistan. They have no providers, they have no equipment, they have no services. So the way they are getting around that is by having these associated physician extenders. So I don't know if people have any comments on that, especially for people from Pakistan.
Can I make a comment?
Yes.
Pakistan is one of the countries where we have more physicians than nurses. So that's one of the problems. The other thing is, we have postgraduates, we have the fellowship, and we have a membership by the College of Physicians and Surgeons of Pakistan. Now, initially the idea was that trainees who do their membership exams, they will be going to the district hospitals and the peripheral hospitals and practice there. And the people who do their fellowships, which is a longer extended training, will be practicing in teaching institutions in bigger cities. But that never happened. So it's again the governmental policies that need to be a little more strict. So in fact, with the two cadres, they're competing against each other, staying in the urban environment.
Thank you very much.
The biggest problem there that the people who were educated, but they were not trained to be able to go and work in peripheral areas of Pakistan with very limited resources. In fact, they had information, no knowledge, and no wisdom of how to use it, let alone apparatuses like blood pressure monitoring apparatus, like pulse oximeter, which is now available widely everywhere in the world. They are not expensive, they are dirt cheap. I don't think it is actually the problem of getting the blood pressure apparatuses or these small equipments. It's about how to actually use the information you actually acquire from these. The basic medical education in Pakistan tells us everything, and that is true for everywhere else in the world, except how to deal with the patient there and then. We are good in taking numbers, blood pressure, blood temperature, oxygen saturation, this, that, and the other, but how to actually do anything with these numbers that will actually make a difference there and then with the limited resources, particularly in the periphery of Pakistan, is impossible. There is no infrastructure for that. And the people who get sent there are the ones who are minimally or not trained at all. How do you expect them to actually deal with life situations that they are there with nothing in their hand?
That was a comment, I think.
Yeah, I think it's more of a comment, but I will just sort of add further comment that in UK, we have tried this concept of physician anesthetist, and still there are, I think, a couple of universities which are training physician anesthetists. These are the kind of fresh A-level students, which we take them up and train them for 3 years, and then they can work in a supervised capacity. They cannot act as independent practitioners, but they can help. Like, I mean, if you are obviously in a theater suite, where obviously you may have one consultant and there may be two physician assistants who can do straightforward cases. And that model possibly can work in Pakistan, but you cannot really just sort of really say that, okay, you train somebody like that and send him to the periphery, that, okay, let loose. And then you're just expecting that there will be more deaths and more complications.
They have started at least. They have started these technologists. They are graduates, and they are doing 2 years training, and then they're going to first batch is going to reduce, I think, in the next few months.
So I think the idea is already taken up by the government in Pakistan, and they are working on it.
That's
so
that's only in Punjab, I think. Nowhere else. Punjab.
In Punjab, yeah, definitely in Punjab. I don't know about Sindh, but in Punjab, these are postgraduate students. They have done graduation already, and they have been trained for 2 years now, and they are going into the practice from next few months. I think they will be
But
into the hospital.
will they be supervised by physicians?
They will be
or
supervised
not?
by the anesthetist, yes. So it will be like technicians, like in America, you're saying. So.
But this is what WFSA is also recommending, because they don't see that the manpower gap will be fulfilled by 2013. But they're emphasizing that the primary responsibility is with the physician anesthetist, and they should be supervising. In fact, they should be training and supervising these people.
Yeah, absolutely. Actually, in UK, they're now training physician anesthetists. Now they are more than what we had previously. Now, physician anesthetists will be acting like junior doctors, and they'll be dealing with the patients in A&E and also in other parts of the hospital as well. And they will have this extra facility that they could become doctors after the end of, finishing another 4 years. They can do another 2 years, and then they can be a doctor as well.
You continue with lifelong learning. So I would like to conclude this talk. Professor Fauzia will be around in the coffee break, so we can obviously have this discussion further.